Good morning, everyone, and it's an honor to present in front of all the stalwarts from Maharashtra. Uh, for the paucity of time, it's like a case report, a rare complication of CSR which I faced. So the clinical history starts in 2016, and it was a 42-year-old male patient who was a regular traveler between Dubai and Mumbai. He came with a history of left eye drop in vision since 2 months, and the visual acuity at that point was 6 by 18, and no history of any steroid use in any form, any obvious stress was not noted. So this is how the left eye looked like, a typical case of CSR, and the OCT also confirmed the same. Patient wasn't ready for FFA, so that was the dilemma in this particular case. This group had published fundus autofluorescence patterns in central serous retinopathy, and they had given various forms of autofluorescence, blocked, motile, hyperautofluorescence, which, depending upon the duration from which the CSR has started, pointed towards the possible leak areas. So, because he was not at all ready for the FFA, and referring to these reports also, I decided to go ahead explaining the patient with the focal laser. So it was something of a focal laser with a modified grid, not exactly, but to staying much away from the foveal avascular zone. And I achieved a very good result within a month. And this is how the OCT looked. The vision improved to 6 by 6 partial, and the patient was very happy. Now, after almost 4 to 5 years, he came back to me in December 2021 with the right eye. Same complaints. He had history of COVID in June. There was a drop in vision since 2-3 months, and he could travel at that point of time. And the vision again was 6 by 18, and this was in the right eye, not in the left eye as previous. And this was how the fundus image looked like. And again, the OCT confirmed it. FFA this time I convinced him to do because I was one time lucky. I thought second time might not be. And there were multiple areas and a halo also around those areas around the superior arcade. And I decided to go with the focal laser, a routine run of the day procedure. And to my surprise, this happened. So there was a pre-retinal bleed while doing the procedure. I tried to give some amount of pressure with the lens itself, and these were the parameters that were used. The OCT confirmed that it was a pre-retinal bleed, and we decided to wait for a week and then observe the patient again. He had to travel back in a month's time. There were some case reports of subretinal bleed, but not of a pre-retinal bleed, which were easily taken care as in this case by a gas injection. So routine side effects are pain, loss of contrast, scotoma, and there are reports of intense burns because of rupture of Bruch's membrane, especially in the high myopic eyes or the retinal vessels. So CSR obviously is a variant or is in the spectrum of pachychoroid. So you may have choroidal vessels also bleeding in certain cases if there are very intense burns. Usually late sequelae is the CNVM associated. So if there is a small spot size use or a longer wavelength, then this is seen. So we waited for a week. Vision was not improving. The option of laser hyaloidectomy was thought about, but I was worried about the elevated retina which was beneath. So the option of surgery was discussed, and this is how it went off. So with all the due precautions for any vitrectomy, ensuring the cannula inside, finishing the anterior and the core vitrectomy, I proceeded ahead for the PVD induction. Obviously, it was going to be a tough PVD induction looking at the age of the patient. So important to watch out for how the pre-retinal blood behaves, because if you are holding the vitreous in the correct plane, you would see that movement of the blood clot. And finally I could see the Weiss ring and the wave of progressing margin of the PVD. So the first barrier was conquered, that a PVD induction was done. And later on I thought this would have been a very easy task to remove this pre-retinal heme, but it was getting difficult as I proceeded, and the particularly this area of the clot was just not moving around. So, as noted by the previous speaker also, proportional reflux came to my rescue, and I had to go very, very slow. So, there are two ways of doing it. Basically, when you do it with a cutter, the wave is parallel to the retina, and if you can use a extrusion tip, it is more direct and it is more effective because it is directly vertical on the retina. But since there was a underlying retina which was elevated, I was quite skeptical to use the direct extrusion tip and wanted to tease it slowly, let it take some time. But I was worried about causing traction on the retina, maybe causing a bleed on table, because as you can see, one area near the superior arcade, which was probably the culprit, few traces of subretinal heme are also seen. And finally, with very low vacuum and working very close at high magnification with a good visualization, I could manage to remove most of it. Still, some part was remaining. Again, with patience, using the proportional reflux as well as suction, I could manage to tease all this out. And finally, it cleared up. I ended the case by putting 5% C3F8, not the routine 14 to 16% C3F8, because the patient had to travel, and advised him to have very strict head down position in the first 2-3 days at least. So I'll just forward the video. Almost cleared up.
It started late. I came here.
And the FGE.
I kept sitting with the cornea people.
So this was how the image was seen on day 3, and at the end of 1 week, the vision had improved to 6/18, and then subsequently, just before he left, the vision had really improved to 6/9. So the take-home message, my learning curve was, in this case, was aggressive laser should not be done. A good head-down position should be maintained by the patient, will obviously lead to better outcomes in pre-retinal heme cases, and judicious use of proportional reflux can take you out of a tricky situation. Thank you very much.
Thank you, Dr. Swapnesh, and we conclude the session.